Hi there, I'm Alan Banks. I'm with GuidedSmile, and I'm with Martin Wanendeya.
Nicely pronounced, well done.
Thank you very much.
Yep.
Dr. Wanendeya from London. And he is traveling the States for a couple of reasons, some teaching this time, yeah. And he stopped by because we have something in common, and that is an affinity for FP1. We manufacture it, and he teaches it all over the world, and especially in our training center in Ireland with Chorus 3D. And I'm fascinated by it because in the States we're mostly FP3, and we're mostly FP3 because that's the way it's been, that's the way they've always done it, and that's the old old adage, why change something that's working just fine. But we mostly do it because of the long-lasting history of the all-on-4, Palomalo, flatten it down, put a denture in, convert it, and now we're into 5, 6, 7, 8 implants, but we're still doing a lot of FP3. Trying to do more FP1 here in the States. There's some companies that are really making a move towards it. But in Europe, it's the standard of care, pretty much. If you're going to do a full mouth, you're finding a way to do FP1. Would you agree with that?
I think it's in different parts of Europe, it's different. We, like you in the States, you've got clear choice. We have our versions of that. We have these centers that are just fully kind of FP3 centers. But I think it's more down to individual practitioners. And if I just start with, if you started as, say, from the pros side rather than the oral surgery side, so as a restorative dentist, it's a very alien thing to you when you first start doing full arches that the first thing you do is this bone that you've tried to preserve for your single teeth, for your multiple teeth, this soft tissue you've tried to preserve. Suddenly you pick up a drill and get rid of it and remove it out of the way. And initially you think, okay, this feels a little bit strange. But it's also, I think I was lucky enough to start implantology when we were doing our version of what was FP1s. I was taught by someone called Ashok Sethi at the Royal College of Surgeons, and I remember that was always his aim, was to end up with that, and he would do these big graphs and go through this long way of getting there. But in essence, that's what I always saw, and I think in Europe we're more going towards that. I was recently at the EAO, which is the European Academy of Osseointegration, which is the equivalent of AO in the States, and it was really interesting because a lot of the speakers there were talking about not anti-FP3 or pro-FP1, more about when you see your patient, looking at them as an individual and treatment planning their full arch for them. So if there's adequate hard and soft tissue, go for an FP1. If there's not adequate hard and soft tissue, go for an FP3. And having that as the standard of care where it's not a kind of one size fits all, but making it more patient-centric. I think the other factor for me is that where I work and what's driven me and maybe a few other people is that the people needing this treatment are getting younger and younger.
That's true.
And as they get younger and younger, I've been in practice long enough that I've had to see my own full arch failures as well as other people's. So when you see this, you ask yourself, if you have a young patient in and you remove a lot of bone and you put the implants in, what happens in 20 years or 30 years with that? When they go again, what options do they have then? And I certainly feel, and I think a lot of people feel, that if you give them another option in 20 or 30 years, that's great. We're giving them implants for life. And it's understanding that this set of implants may not be their last set of implants. And I think that's one of the things that was a real realization to me.
Which is a great philosophy, right? These young patients, we're seeing a lot more of them, methamphetamines and other reasons. I mean, even if it's soda pop or neglect, but a lot of younger patients. But what we found is that in those patients, the tough part of it is finding prosthetic space. You make an FP1, and here pretty much an FP1 means a roundhouse prosthesis. Now an FP1 could also mean all the teeth come out, implants go in, and maybe you could make some bridges, some of them direct to implants and make some room. But we end up with no space, and you can't just open a bite on a young patient to make space. So then, is there a good answer for that?
I think, as with implant dentistry, it's always about space, and none more so than in FP1. And I think the difficulty is you have to start to look at it not just as how do you fit the implant in, but how do you fit the MUA in as well. Right. And that's really one of the crucial things, is you have to make room for the MUA. You have to understand that the MUA and the implant function as a unit. And if they function as a unit, you have to then decide on their positioning that's going to give you enough prosthetic space, so that two things: one is you can get the aesthetics, you can get the function, you can get the phonetics, and most importantly the material, because I think that's really where a lot of people or a lot of changes have been made towards moving towards more aesthetic materials such as monolithic zirconia. Having the option of having the right thickness and the right amount of volume of material is really, really key and crucial. So this comes down to kind of starting your planning from knowing what you're going to produce, not just in terms of where the implants are going to go, but what material you're going to use at the end, and putting that into your thought space at the beginning of the process, not as an afterthought.
It's all about criteria, it's about education, and it's having rules. You know, you're developing some rules, some type of book that, or recipe, if you will, based on how the patient presents, to help doctors categorize them based on, you know, youth, space, smile line, whether they should be an FP1 or FP3, based on criteria that they're walking in the door with. Isn't that right? You're kind of developing that?
I'm in the process of doing that, and I think what's been interesting is
put you on
seeing,
the spot. Rumor has it.
But it's really seeing, I think, how you guys work here, about how you've really, really systemized your approach to Chrome Guided Smile, and taking away some of what you've done for that and saying, look, how do I apply this to make it easier for other people to follow? When we're teaching courses, we know what we can show and teach and train people to do. But I think a lot of FP1 ends up being more art than science, and what you guys are after is more systemizing it and making it, you know, effectively systemizing art is, I think, what James Hamill called it. Finding a way to do that. And I think some of them involve around where you place the depth you place the implant relative to the gingival margin of the tooth. Some of it involves really being very specific about your implant system and about specifically the MUAs, the multi-unit abutments your implant system has, because not all MUAs are the same. If you have the option of smaller, narrower ones, this gives you so many more options in terms of FP1. If all you've got are the standard 4.8, the Nobel standard, I'm going to call it, MUA, then this gives you less options in terms of what you can do restoratively. So some of the rules are around, first of all, knowing your system, knowing what MUAs you have, then knowing the emergence of those MUAs. Then once you understand the emergence of those MUAs, knowing whether you need to put the 1.5 or the 2mm or the 3.0. So a lot of it is going to end up being more system specific, and that will be according to what your system has. And I think what we're hoping to see on the market, which we started to say at the EAO, was more MUAs specifically designed for FP1. I know some companies have them. I know, for instance, Dentsply's got a very narrow one in terms of the uni abutment. I know there's also the microconical abutment with some systems. But having these is a real help in terms of developing, first of all, the emergence profile, and also making sure that you don't impinge on the papilla on either side when you're trying to create ideal aesthetics for this. And in terms of the rules, it's working on those, and I think taking inspiration from the stuff that you guys are doing and seeing how you are really drilling down and thinking through every step of the process and questioning yourself. So I think that's what's taking the time, is looking back and saying, does this work? Is there a rule for this? If someone was to apply this in 4 or 5 situations, would it still hold? And I think that's where I think the simplicity of the book that you've created in terms of your guide really undermines underneath that is a lot of complex thinking. And I think with time this will come. I mean, I've written a book chapter in, if you have a look in the graftless solutions for the edentulous patients, Saj Jivraj, there's some information in there. There's an online course with Osteocom which goes through some of those things. But I think there needs to be another stage, another level to make it more, I'm going to use a word that someone used, more democratic. And the democratic means making it easier for anyone with a reasonable set of skills to get a reasonable result with an FP1.
And then also to pick the right patient for it.
That's the crucial part.
That's crucial.
I mean, and that starts off with, in some ways, just your treatment planning, your understanding of the biology. But you know, I hope that most people doing full arch, in fact, I know most people doing full arch know how to treatment plan and do everything else, but it's applying a different set of rules than what you're used to when your patient walks in, and selecting the right patient is really key.
We find that if 10 cases come in for FP1, maybe 6 or 7, 3 or 4 qualify for all kinds of reasons. And sometimes it's just the basic, it's a gummy smile, and it's probably not the right protocol, not for long term. But others would be, bone is in not an ideal position. The patient's been without posterior teeth for a long time, so there's elevation from sinus. There's like all kinds of criteria that just almost disqualify a patient. And so maybe the patient's already been promised something that is this, and now they're completely disqualified. They cannot have an FP1 for several reasons or one reason. But they already have an expectation. So wouldn't it be nice to have at least a foundational criteria that before the patient is treatment planned with them, that they know where they're probably going to fit, for what reason?
I think if I could just reflect on what we teach on our course that we run in London, the FP1 course, which is to start every full arch patient the same. To go through the same process in terms of looking at their smile, looking at where you want the teeth to be, once you position the teeth, then doing a diagnostic wax up, figuring out where the bone is, and then working out what you're doing from there. But we tend in practice, and what we teach is we don't promise it until we're at a certain stage with the records.
I see.
Because that way we won't actually know until we've got certain bits of information back and gathered certain things, whether they qualify for an FP1 or not.
Part.
And then this, I think, is important, is to say to the patient, look, you may be suitable for this. This is what it involves. If you're interested, this is, this is what the procedure will be. If you're not, we can give you this. And just to make sure you sit on the fence enough until you know for certain. Yeah.
That makes sense. But then there has to be the whole educational component in there. As you're trying to fit them into what they need, there's got to be some educational foundation. Where am I getting mine? Where am I getting it from? And then one other thing is two of them. Should I presume that you try to do as many straight implants as you can?
Yes. The reason is that I think a lot of companies have the angled MUAs. It's really difficult to do things. You've got to create the emergence profile with the MUA, and the angled ones are slightly bulky on many, many systems. And also you've got to get the timing right. If the implant is slightly too deep or slightly too shallow, suddenly you lose a papilla mesially or distally. Or even if that's right and you don't have the exact component, then you might not get the emergence profile from the head of the MUA through to the gingival margin of the tooth. So with all of these things, yes, it is possible to do it angled, and I have done it angled, but it's always, I think, one of those where in some ways, you need to make sure you get the implant in exactly the right position to be able to recreate that.
For sure. And you also, with an angled, you are going to remove that precious bone to seat that implant 6 millimeters subgingival. 3 millimeters subcrestal sometimes. And when you have an emergence like this from an abutment, that's just a lot of profiling. And often you don't even get the abutment seated.
But depending on the height of the MUA, because some of them are really, really tall on the back end of it, meaning that you might need to sink it even deeper. And again, this comes into, you look at your implant connections, because I think making sure you've got a connection that's really tight and that's going to hold bone, because if you remove all of that, you want the bone to remain above that level. So there's a few other criteria within that. So I tend to really, really try and avoid angled abutments. And when I'm really forced into a situation where, for instance, one of the situations you described, where we've got, say, for instance, teeth 3 to 3, bone 3 to 3, nothing 4, 5, 6, I will sometimes only place implants in the anterior with a small cantilever, graft the posterior, then come back and place those at a later date, and then link it all up later. So there's ways around it. And I think this is where, once you start to see the possibilities of what you can do and you start to see ways around it, you can think about the skills that you have in terms of grafting, hard and soft tissue, sinus grafting, maybe even some bone augmentation in areas where you don't have enough. So all of these come with time, and I'd say not your first case if this is something you're used to. But this is where sometimes the complexity about putting it down as a cookbook and a set of rules comes into play. And I think, when we were talking earlier, I said, I think that some of the cases fall into different categories. I think there's some cases that walk in and you say, look, you can really easily make this case as an FP1. Generally with some of those, you can really make them easily as an FP3, so you have to decide if that's what you want to do. Others are a little bit harder, and those are what take the time, and that's probably what's going to be a little bit harder to fit into a rigid set of rules, and it's also just dependent on the skill set of the dentist at the time.
Well, but as you mentioned, skill set for sure, but as we were talking before, it's also price point. And if the patient perhaps could have this FP1, more conservative approach, but they have to have more surgery, then you charge more, the treatment is a little bit longer, and you still have the same outcome at the end or something similar.
Yeah, I think it's important that when we talk on our course, we talk about this, the fact that it will take you longer, it will cost you more. And because it will take you longer, it will cost you more, I think you should charge accordingly. And it's interesting because we're talking, because your price point as a lab for the provision of the final is similar, whatever the material. So it really comes down to chair time. And I think chair time and planning. And I think if you just make sure you're adequately compensated for that, in terms of when you look and give out the quotes and the estimates to the patient, and you have a way of talking to them that explains the difference, then you end up, I think, in the same place, you know, in terms of financially. And for a lot of people, they feel, no, it's too expensive. I say, no, well, if it's 5, 10, 20% more, maybe you just add that to the patient estimate and then make that something that in some ways they pay to preserve their bone.
And maybe it's an a la carte item, so it's not a little miscommunication between this practice and the practice down the road that's just doing traditional FP3. Because this is they see the difference in price and go, not really apples to apples here.
Well, I think this is where it comes down to that initial conversation we have with patients. We tend to, when patients come in, say, look, there's a couple of options for you. The standard approach would be to do it this way with an FP3, which would cost you X. However, you could be suitable for an FP1, which will cost you Y. The advantage of this above this is this. The advantage of this above that is that. What do you want?
Right. Maybe you make them want that.
And at this point in time, it's interesting because looking at your signature prosthetics division and all the things they do, it was very interesting looking at that, because the sort of people who may choose that, the sort of people are going to want your signature prosthetics with the individualized crowns, with the staining, with the choice. Would those people pay a little bit more? I think so.
Yeah, probably
I think so.
Yeah. One more thing. The universal shapers drills, has that changed for you, how you approach? I mean, because before it would be freehanding in a smaller burr and more art, but now it's plunging with something that's in the software that gives you an emergence profile that you know before you go. I mean, has that helped?
That has been really, really one of those things that you look at and you think, why didn't I think of this before?
That's what I thought.
Because what you're aiming to do really is to create a pontic shape. And two things. One is a pontic, and the second is sometimes to fit a slightly wider MUA.
Yeah.
And having this thing that allows you to contour the bone to give you the ideal emergence profile to then create the soft tissue. And I think the key part is having it as part of your stack guided system. So it clicks in, you drill with it, it clicks off. There is sometimes a little bit of more that you'll need to do when you look at, you think, I'd like that slightly wider, slightly narrower, or maybe that's me because I think that way. But
you are watching
it. Yes.
The key is you're watching it, so you'll know if you want a little bit more that way, as opposed to hidden under plastic. Yet the whole thing is right in front of you as you're plunging.
And having it open so that you can see what you're doing, you can see where you're amending tissue, etc. And I think this is where it comes down to. One of the things is, why is there less provision and more provision? I think the first is education. I think the second thing is having a way to do it easily. And if we can make it so that this is easily accessible to more people, then more people will do it.
For sure. Yeah. Now, when you're using universal shapers, are you just using the mushroom, or are you actually using their kit to make the osteotomy?
I'm just using the mushroom at the moment. Right. I know that we've spoken about a way in which we can use potentially that for other things, which James told me about the other day. But really what I'm doing is using it for shaping pontics.
Yeah.
And sometimes as well, with an FP1, if you're placing the implant palatally, so if you imagine a traditional immediate implant, you go up against the palatal wall, but when you have to put the MUA on, it's a little bit wider.
Right.
So this means you need to take away a little bit of the palatal bone, but doing that in a controlled way that still leaves you enough to hold the implant and to get the nice aesthetics, and takes away enough so that you can get the MUA on, has been really, really useful.
Right.
So it's useful for pontics and for emergence profiles.
Yeah, and with the abutment that you use, you don't have to plunge all the way down to the implant. You're doing it right from the top of the MUA, from the margin.
Yes.
Because your MUA is narrower than your implant.
Yeah, no, the MUA, I think...
For the straights.
For the straights, the 3.6 uni abutment, which is 3.6 wide, is beautiful for that. It means that you put the implant in and the abutment will go in without any contouring needed.
Right.
So the contouring is only needed at the point that the abutment comes through. But for posteriors, I tend to use the multi-base there as well. So there I might need to use it in certain scenarios. Yep, just to again open up around the implant before putting on the MUA.
And when you're planning the case, do you have the mushroom actually brought into the software so you can see it relative to the tooth, the neck of the tooth, and the emergence?
Well, that's what happens in the planning stage.
Yeah.
You know, when you get the guide, all of that is planned, all of that arrives as part of the kit, and all of that is baked into this. So I think, although yes, I can do it freehand. Or not freehand. I would use some sort of stent or guide every time. Sorry, I need to make sure I qualify that. But having something that allows you to make all the right shapes and the right holes means that when I had come to do other things, which are the things that give it the nice aesthetics, I've got more time for soft tissue grafting, more time for hard tissue augmentation. I've got time to do all those things because I've not spent time at the surgery doing something like making sure that the initial osteotomy is in the right place and the implant goes in the right place. It saves me time for the bits that are going to make the difference in terms of the aesthetic outcome, rather than spending time on the things which, you know, you can do freehand, but I think if you do it with the guide, can really, really speed you up.
Yeah, yeah. I think you and James are really working out a nice process for that.
Well, I'm looking forward to seeing the different iterations, and I think what's been interesting is seeing, I think, how quickly things are changing and how quickly the response has been to new things coming out. You know, every time we meet, this thing new, that thing new. So it's working out how to get to the best of this process, and then making it really, really, like I say, democratic, so that most people can do this. And I think that was the aim when we started teaching courses 5 years ago, you know, with Nick Sisodi and Paolo Cavalli. When we started teaching this, is to make this accessible to as many people as possible, rather than just to show our nice cases online and everyone go, wow, how did you do that? It's like, okay, we're going to tell you how we did it. Then it becomes your choice as to if you do it or not, rather than it's not accessible to you as an implant dentist.
A few booked meetings or courses already at Chorus next year. Did you pick dates yet or no?
Dates are coming. Dates are coming. Dates are coming. We literally had one last weekend, so that's just gone. And the Guinness is still settling after meeting James. And there'll be a couple next year that go, and we also run some in London that are not with Chorus, but again, if that's there. So I mean, if people want to know, they can find me LinkedIn or socials or whatever, and they can find out more from there. Okay.
Sharpen your skills in Europe with Dr. Wanendeya. Yeah, I'll post the dates once we have them. And
that's very kind of you. Thank you, Alan.
And we're so grateful because we, you know, like a lot of laboratories and implant planners, sometimes we do live in a little bit of a bubble, and we don't want to. We have to keep expanding and developing and following great techniques. So I hope this recipe book comes out soon, and we can help train a lot of doctors over here in the States as well.
I hope so too, because I think ultimately it will benefit patients. I believe it will benefit patients, and that's the reason for doing it.
Yeah. 10-4.
Okay.
All right. Thank you very much.
Thank you very much.
Talking through this.
You too. All right.
All right.